Hi, everyone. Welcome back. That was an incredible conversation and a lot of really exciting chat happening during that conversation. I am going to, and I'm happy to say that we did have a winner for the first door prize. So congratulations, Judy. We are going to be moving into a couple of questions that came up during the talk between Dr. Carlesso and Dr. Hawker. And then we're going to be moving into our next segment. So I'm going to invite back Dr. Yen, Dr. Gonzalez, and Dr. Carlesso to come back on so that we can go through a few questions and then move into the next segment. Hi, guys.
Hello.
Hello.
So one of the questions that came up based on the discussion was 40% of people having OA seems low compared to what has been kind of communicated broadly in social media or other facets. Is that an accurate, or is that only 40% are experiencing pain?
That's a great question. I mean, I would say, well, that is based on, I guess the best epidemiological studies that have been done. So they tend to be, they go into cities and they track people for decades even to see, who develops OA and who doesn't. So I would say, it's a combination of having the diagnosis and being symptomatic based on those studies. And yeah, there's been a number of them that have been done. So I think that's a pretty, it's a good ballpark figure out there.
It sounds like that some of the difficulties with that would simply be, again, like you said, X-ray findings. By the time you see OA, it's already too late. Like you probably already had OA or osteoarthritis in that manner. So if anything, I'd almost think that would be more of an underestimate as far as what the actual prevalence is. Plus, in a lot of these studies, if they're basing it just on X-ray findings, like again, they in order for them to say an official diagnosis, again, those epidemiological studies, are they basing it more on X-ray findings? So if that's the case, it's probably more prevalent. So if you might hear more in other instances, I would probably lean almost towards the higher number, just because we don't have an accurate way of diagnosing it from when I say diagnosis of symptoms, it can be asymptomatic, but you wouldn't necessarily have an accurate way of diagnosing if you have the factors that lead to osteoarthritis in a nice, easy, simple test that you can say, yes, you are going to develop osteoarthritis or not. So.
Yeah, I would agree on this because I think it's probably underestimated. The reason being is, why would you get an X-ray if it weren't painful? So if it's not necessarily painful right off the bat, like the only reason to get it is because you have a clinical suspicion of it, or you've bumped it or you heard it or something like that, then you would get a picture. But no one's going to get a random picture for no good reason. So it's probably underestimated.
Perfect. So one of the other questions, and I think this came up a few times in the chat, there was a mention of a toolkit. We have absolutely heard your requests. We are going to be putting that toolkit into the chat on the live stream so that everyone can access it. And then hopefully it gives you some more information that you can take and use in discussions with your family physician. The other question, the last question of this topic, and then we'll move into the Mythbuster section, is where's a good place or ways to provide help to physicians or healthcare practitioners about arthritis specifically, since this person said often the misconceptions are being spread or communicated by physicians or healthcare practitioners. So where's a good resource to direct them?
Yeah, I know I'm in Ontario, and I know the College of Physicians and Surgeons here has put together a toolkit for them. And that's actually, to my knowledge, that's available on the Arthritis Society website, as well as the college's website. And so that would be, kind of like the physician version of what the patient version that we just are posting. So it's meant to help physicians with their diagnosis of OA and interactions with patients and helping them manage them.
Perfect. So the next segment we were going to get into, which I think I'm really excited about, this is the Mythbuster section. This is all those times that you go on Google and Dr. Google ends up being the resource, and there can be some really scary things out there. So we've collected some questions from the audience as well as internally to ask you guys. So jump in. Anyone is open to answer. One of the first ones I want to start with, I've been told by my doctor there's nothing I can do to change the progress of this condition in terms of exercise, medication, or lifestyle. Is that true?
Such a timely presentation. I think, Lisa, I'll let you take that since you were here.
Sure, yeah, absolutely not. I mean, and I think Dr. Hawker said that she's seen people's x-rays change after weight loss, after exercise. And there's been numerous studies that have shown that. Basically, if you're decreasing the load on the knee, either through improved strength or through less weight, or maybe you're changing your activity habits, that you're not doing something that's been particularly stressful for the joint. Absolutely, we see, particularly through the use of MRI imaging, that changes do happen in the cartilage gets healthier, the joint space can change a little bit, and importantly, people's pain changes and their function improves.
I think another thing to consider is that the understanding of osteoarthritis is constantly changing. And I'll have to admit that, thinking about osteoarthritis in terms of degeneration or deterioration or wear and tear, it's a long-standing kind of education thing that we've held on to for so many years that honestly, you as a patient having this information in front of you, you're going to be the best advocate. So you're going to be hearing it over and over again that there's nothing you can do, and it's going to happen with your family doctor, with a physical therapist. Like there's a lot of people that still have that information. So part of this becomes where you become the advocate in actually informing or updating your physician or your healthcare provider of what the current understanding of osteoarthritis is. Because with this newer current understanding of osteoarthritis, then people start to remember, then people will start to realize that there are things that can be done, and the importance of exercise, the importance of activity. Because right now, when you think of it as degenerative, deteriorating, or wear and tear, it does give that impression of there's nothing you can do. But if we start to go away from that, that'll be more helpful. The difficulty, I think, though, is that when you get an x-ray, a lot of times the radiologist will define it as a deteriorating or degenerative joint disease. And so it's kind of like you're fighting other specialists who you believe or whatnot. And so all of you being here today and getting this information, you probably have in many ways, you may have more up-to-date information than even what your current healthcare provider has. This is where you become your own advocate and helping them to keep up to date with their own education.
Awesome. So here's another one. I've been told if it hurts, I should just stop what I'm doing. Is that not right?
I think we know the answer to that. Yeah, absolutely not. So very important to keep moving and keep active, to keep the joint healthy and to keep the muscles strong and all the tissues in the joint healthy. But as I think, as we acknowledged during the conversation, it is a tricky thing to figure out what's okay to do and what's not okay to do. It's a bit of trial and error as far as the pain that you experience. And I guess what's important for people to know is that the pain, if you have pain with activity, it could be something as simple as walking. You're not doing increased damage to your joint. You're not creating more deterioration or anything like that. Unfortunately, we don't fully understand the pain processes in osteoarthritis. And so, that limits us for providing a more fulsome explanation of that. But we do know that pain is not a good indicator of any kind of tissue damage during activity. And it's just the opposite. It helps with joint health and pain management overall. So I would say try and find things that you like to do. And if you can't do them at the same level or intensity that you used to do, then try and modify them, because doing meaningful activities is important. And if that doesn't work, then try and find a new activity, and just try a graduated approach in terms of how much you do, so that you can figure out what your pain response may or may not be and what's acceptable to you.
I'd like to, oh, sorry, go ahead, Ken.
Yeah, so I think that's actually that's all really good points, and certainly incorporating all the stuff that we learned from the recent presentation, is that if we are under the understanding now that it is not due to like a purely just degenerative type of process, then we now can understand that there's things that we can do to change this in the future. And so then we can have more confidence that if we are doing things and it's exercise and it is uncomfortable, that we're not actually doing something which is negative. And then therefore, we're not as concerned that we know that we're not breaking things down, we're doing activity. So then having the perception of not actually causing damage to yourself when you're doing activity, then it actually means that the pain that you actually experience could be a bit lower, because half of it is actually, it's a pain thing. So if I'm concerned that every time I move, I'm causing worsening degeneration, then if I get a bit of discomfort, it's automatically going to make that feel significantly worse. But if I know that this is actually not the case, and that I'm not worried about causing my joint to degrade or degenerate far further, and in fact, it's actually helpful, then my perception of it is like, oh, okay, maybe it's a bit uncomfortable, but if I keep on moving, it'll probably just limber up a bit and it'll probably be easier next time. So having the understanding that we're not damaging ourselves will actually make that your exercise more tolerable.
Awesome.
Just wanted to add, so a lot of times when it comes to exercises and activities, I always talk to patients about the extremes, right? So you don't want to be completely sedentary, not doing anything, but you also don't want to be, taking gymnastics now and doing things that are outside of what you normally would do. So there is a bit of that balance, that halfway between, and this happens in life in general. Extremes usually aren't the best, eating too much sugar or eating too much, whatever the case. So even with activity, I'd like to highlight when Lisa talked about the graduated approach, and part of that is it may hurt when you move, but find a level of movement or level of activity that actually doesn't cause you as much pain. You start there, and it doesn't mean that that's the only thing you'll be able to do. What you may actually find is, as you start to do that lower level of activity, it's going to feel more and more comfortable. Then you can start to gradually increase that, and as you increase that, you can keep doing more and more, and as you may then even get back to the point where you're back to the same level of activity that you were beforehand. So take that graduated approach, takes that slow approach, and just slowly increase it, and you may find it works better that way. But the one thing that you don't do, if it hurts, just don't do it. I think that's erroneous. I think you do still have to find something that you can do, modify it to something else or a different type of activity that you enjoy.
Awesome. I do have one more, and I think it's a really good one, because there's a lot of times where we've talked a lot about the ambiguity of pain and the subjective experience of pain, along with the imaging and all of the different factors when you're coming up with a picture of someone's journey. Someone asked the question, can an SNRI help with pain?
I'll let the docs take this.
Well, okay, so can it help with pain versus can it help with osteoarthritis? Those are two entirely different things, because what we're talking about, of course, is arthritis and pain. And so they may, and sometimes they match, and sometimes they don't actually match. But pertaining to pain, it absolutely does make a difference, actually, because the worse and it actually goes both ways. The worse your pain, the worse your mood. And the worse your mood, the worse your pain. Worse your pain, worse your mood, worse your pain. They're actually kind of very much related. And of course, if your sleep is bad, worse your pain, worse your mood, worse your sleep. Worse sleep, worse your pain. Worse your sleep, worse your mood. Mood, pain, sleep, mood, yada, yada, yada. It is, they're actually very much tied together. So if you're able to break into certain things and get some benefit from the mood component of things, that actually does make it easier to return to doing some of the things that we like to do. And returning to doing some of the things we like to do increases our ability to do our activity. It motivates us more to do things. And by doing the things which are helpful for us, it actually causes a release of our own natural painkillers, actually. We have endorphins that we actually generate from doing physical activity, being with friends, doing hobbies and such. These are actually ways that actually help manage our pain as well. And in fact, our body makes a bunch of endorphins for these types of reasons. It rewards us for doing activities and such. However, these are all limited if your mood is really, really, really low. And if your mood is really low, then you won't be able to do the things that actually make us enjoy life and make our bodies release our natural painkillers. So it actually is a way of self-regulating our body by, if we can have our mood better maintained, then our pain is a little bit better, and vice versa. The worse your pain, generally the worse your mood, and it kind of spirals.
One of the ways I've described to patients is that pain pathways and mood pathways, they actually share a lot of similarities, or they contribute to each other. So when it comes to things like SNRIs or Cymbalta or duloxetine, for example, the mood issues, these pathways all either amplify pain or they can actually decrease or inhibit pain, just like Dr. Yen was talking about. So these medications are actually not working on the actual joint itself and changing the mechanics or the inflammation happening into that area. Rather, they're modulating the pathways or the highways that go from you experiencing pain from the joint to the brain. And those pathways can be modulated by using Cymbalta. So by using something like the duloxetine or SNRI, you're modulating those pathways to either increase more pain inhibition or decrease the sensation of pain coming back up to the brain. So this is why you have these types of things. And quite often, if you take an SNRI like duloxetine, when you look at the dosage compared to taking it for something like depression, it's lower. So they talk about 30 to 60 milligrams for duloxetine, whereas for depression, they're talking about 120 milligrams and up, right? So they know, but there's definitely, like Dr. Yen said, there's a mood component. So it's probably, I mean, all these answers are correct. And so this is why they're twofold. So yes, the Cymbalta helps not just with the mood, but there's also some similar pathways that help to modulate pain as well.
All right, and the last one, a few people have actually sent in questions around diet. So you are what you eat. Is that true in terms of osteoarthritis? Is there a diet that can help?
So I can comment on this, so one of the things that you've seen in the previous presentation is that one of the things that you look at is, for example, we'll take obesity or being overweight. We know that the more adipose tissue that you have means that you're potentially setting up your body to have more inflammatory, in a more inflammatory type of condition. So if we kind of take a look at it from that standpoint, then can we look at then diet and different types of diets that could actually promote more types of inflammation, right? So eating high sugar, for example, can actually promote a lot more inflammation. This is why patients with diabetes, for example, who have uncontrolled levels of glucose in their bloodstream, they actually have increased kind of inflammatory response. This affects so many different parts of their body and the different complications. So losing weight, managing those things, and including your diet can actually be very helpful. So is there a role for diet? I do believe so. And the thing is, inflammation actually causes a lot of other things other than osteoarthritis too. There's also even some studies looking at what happens into your gut. Your gut itself is a huge pharmacy. So your gut, there's lots of bacteria in there, produces lots of different types of pharmacological drugs, so to speak, that your body gets, and you are what you eat. So if you're eating things that are high in sugar, then the bacteria in your stomach are producing a lot of these chemicals that result in a lot more inflammation. So if you start to eat healthy, less processed food, that can change the bacteria gut, the milieu that's happening in there, potentially setting yourself up for a lot less inflammatory response, and then therefore actually in an indirect way anyways, potentially helping you from an osteoarthritic, but really in a lot of other conditions. It's not just osteoarthritis. There's a lot of other conditions where diet can be helpful. If it's other than physical activity being like one of those magic pills, the diet could be the kind of other type of magic pill that we're looking for.
Yeah, I'll just echo what Dr. Gonzalez said, and particularly about the gut microbiota. That's a very active and new area of research in osteoarthritis. And I think in the next probably 5 to 10 years, we're going to be seeing lots of exciting results coming out of that. So, but it is a very much an emerging area. So nothing significant to report quite yet, but something to keep an eye out for. And Dr. Gonzalez, you made a great point about how inflammation is related to obesity because it's actually related to fat content in our bodies. And so in terms of diet and relationship to losing weight, it's not just about decreasing the load on the joints, but also decreasing that fat content, which tends to hold a lot of an inflammatory component, which can contribute to our pain.
Awesome. Well, thank you guys. I think there might still be some questions coming in, and sorry if we didn't get to yours. If we have time at the end of the day, we will. Thank you guys.